Oh, hey! Thanks for joining us today. I didn't know we were live right now. So, this is Sergeant Ryan McDonald with the Vancouver Medical Recruiting Station here in Vancouver, Washington. We do have a treat for you today. I have Colonel Martin Schreiber, who is a general surgeon for the U.S. Army, as well as a professor of surgery over at Oregon Health and Science University right here in Portland, Oregon. So, without further ado, I would like to introduce you to Colonel Martin Schreiber. Sir, if you would like to take a second and just kind of tell us about your Army story, kind of what inspired you to join the Army as a general surgeon, and anything else you would like to share with us. So the floor is yours, sir.
Well, thank you, Sergeant McDonald. My story goes back to 1984. I was finishing college at the University of Chicago and looking at about a $20,000 debt, which back then seemed like a huge amount of money. I'd always sort of been interested in the military and had an interest in being an officer. So with that debt and the interest in the military, I chose to join the Health Profession Scholarship Program, which, believe it or not, was alive and well 36 years ago.
Yeah.
So my girlfriend in college gave me the oath of office. I don't think you can do that anymore. And I went to medical school at Case Western Reserve University, and on the scholarship, which essentially paid for the entire tuition as well as equipment. Following my medical school period of time, I actually ended up in the Pacific Northwest, which was always another interest of mine, at Madigan doing an internship. And just as a side story, I just got back from Madigan. I did my AT there in March. There were no less than 3 physicians that were still working there 36 years later. And all 3 of these were civilian contractors that had been colonels in the Army in 1988. They're still there. At that point in time, it was a one floor hospital, multiple buildings. The operating room was about half a mile away from the emergency department. And if you had a gunshot wound, you had to put them back in the ambulance and drive them to the.
Wow. Okay.
And one of my partners, Bob Martindale, was the chief resident. I was an intern. We actually had to do that one time. We took a civilian casualty who had a shot in the abdomen, drove him to the operating room. The door was locked and the lights were off. So Dr. Martindale kicked the door down, and we started put him on the table, and everybody started showing up. We operated on the patient. They actually survived. But after that, I did a 5-year residency at the University of Washington in Seattle, and then fellowship in trauma, critical care, and acute care surgery, and then spent 4 years on active duty at William Beaumont Army Medical Center as the chief of trauma and critical care. Then 2 years at Ben Taub in Houston, while still in the reserves as chief of trauma there. In the last 18 years, I've been in Portland at Oregon Health and Science University, rose the ranks to a professor. And during the period of time that I've been here, I've actually been deployed 3 times. The first time was to Iraq in 2005. And at that point in time, I was the chief of surgery in Tikrit, Iraq, at a busy combat support hospital. And we took care of numerous casualties, up to 30 at a time, in fact. From a blast injury, a mass casualty event that started in Mosul, and they transferred us about 30 patients to Tikrit. So I did that deployment. Following that, I was the Joint Theater Trauma System Director in Afghanistan, primarily operating out of Bagram. And actually, these are some pictures from there with some Air Force colleagues. I was traveling around theater, assessing resources and personnel, moving people around. Best job I've ever had, frankly. I had a letter in my pocket that said I can go anywhere I wanted, anytime I wanted to, and I just show up at the airport and say I want to go anywhere, and they'd take me. They'd say, "Sir, sit over here, drink some cool water, and we'll call you when the plane's ready to leave." So I did that, and I really enjoyed it. And my last deployment was to Shank in northeastern Afghanistan, where we were sort of the head of the spear, multiple special forces operations going on, and the war was raging, and we had numerous casualties. That was in 2014. We were there in April of 2014 when they had their election, the Afghan election, which we supported, and it was a great opportunity for terrorists to just shoot down people, and we had numerous mass casualties, and learned a lot about how to take care of patients. And probably out of all those three deployments, really formed the doctor that I am today, and shaped medicine, trauma medicine in the United States in the civilian realm. And that resulted in my research interests, which have been pretty sincere, almost all combat casualty related, war related. And my sort of military and civilian careers are really kind of unified by my experiences in the military and what we've done there, which was really some of the most amazing experiences of my career.
All right. Sure. Thanks for sharing that. I did have one question on what you had said when you talked about like deploying while you were a civilian here at OHSU. How long would you say your deployments are? Like, where you can just pick up and link up with a unit and go deploy somewhere. How long would you say that deployment is? Like, do you get to choose or what?
So our deployments as reservists in the Army are primarily 90 days. They call it 90 days boots on the ground. So when you hit the dirt, you're there for 90 days, and they're pretty good about keeping it to that. It takes a couple weeks to get there and a couple weeks to get home. So you're gone for about four plus months, 90 days on the ground, basically. So the Army has done a really good job with that. It's not always the case with the COVID events and freezes on travel. That may change. That has changed somewhat for people, but as far as Army Reserve goes, it's pretty good about keeping it 90 days boots on the ground.
Okay, that's good to know. I'll definitely be sharing that with the students that I meet over at OHSU and all the other colleges that we attend. So, do you have anything else you'd like to add about your Army story or about your background before we get into these questions?
I gotta say, one of the major things the Army did for me is it created sort of a second life, in a sense, where I have a whole set of friends, that I only know because of the Army. When I mentioned that I went to William Beaumont Army Medical Center, that's in El Paso, Texas, and in a typical Army way, somebody I didn't know at all invited me into their house. I ended up staying there with my wife for about 3 months.
Wow.
And we finally bought our own house down the street. We ended up having a double wedding when he met his wife. So that's that's my best friend in the world, and that's an Army friendship. And I think that's typical. When you meet people deployed, they really become like your closest friends. It's not uncommon to be, you're 2 feet away from them for the entire deployment. You're having deep conversations, sharing problems and issues, and they become lifelong friends. And it's a whole part of my life I wouldn't have if I wasn't part of the Army. And I really appreciate it, both from the aspect of what it did for me personally, but also professionally.
Awesome. Yeah, I can definitely relate to what you're saying. I mean, I could not talk to a group of friends of mine that I've served with for 6, 7, 8 months, and then the minute that we start talking again, it's like we never even had that break of time that we didn't talk. So yeah, most definitely, I feel the same way.
It's really unique. The relationships you make in a deployed setting, they're unique. They're unique relationships. You don't get to know people like that at work in a normal environment. Everybody's in their own offices. You interact occasionally. These are really extreme exposures to people, and you form really close relationships, lifelong relationships.
Right. All right. So I'm gonna get going on question number 1. I'll have it up on the screen here, but I want to ask you, what is your greatest accomplishment while serving as a general surgeon in the Army, and then also on the civilian side, if you don't mind answering kind of both those questions?
So if I was really honest with you, I would give you one answer, but I'll give you 2. Uh, the greatest accomplishment I had was when I was the Joint Theater Trauma System Director. That person really makes the major decisions about how injured warfighters will be cared for in theater. And that was, at that time, Iraq and Afghanistan and anywhere else there were injured warfighters. You lead a video teleconference once a week where, 2010 was the busiest summer in Afghanistan. We were having somewhere around 800 casualties a month. And all of those that came back in the ICU to launch still were reviewed. And it was a multi-continental review from the dirt in Iraq and Afghanistan to the roll two to the combat support hospital, back to Germany, back to the United States. And at each level, there was somebody on the call or video that would review the patient's care. And there were a set of clinical practice guidelines that everybody was expected to perform to. And during the review, if the clinical practice guideline wasn't followed, you would ask, well, why didn't you do what you were supposed to do? And, we don't even do that in the civilian world. I mean, that is an incredible care being delivered. And to this day, they're still doing these video teleconferences. And, now there's several of them are about coronavirus. There may be 1 or 2 casualties a week. Some of them are just motor vehicle crashes, motorcycle crashes. Back then, we were reviewing about 18 cases a day, 18 cases on each of these video teleconference days. So you were contributing to these clinical practice guidelines, which was shaping the way that warfighters are being cared for, and then traveling throughout theater to make sure that resources and personnel were in appropriate locations. So that was by far the best job I've ever had. And I think it had probably the biggest impact of anything I've ever done. So that would be my answer to that. In terms of civilian world, what we just completed a major study of 1,000 patients in the pre-hospital setting, where we randomized them to a drug called tranexamic acid, which is a drug that's been used for hemorrhagic shock. But we use this in brain injury. And this was done throughout North America, about 18 centers, 1,000 patients. And we found that 2 grams of TXA given pre-hospital resulted in improved survival after brain injury. And the Committee on Tactical Combat Casualty Care, which determines how injured warfighters are cared for in theater, is changing their guideline to do this, to give 2 grams pre-hospital of TXA for both brain injury and for hemorrhagic shock. So having done that study in the civilian setting and then have the military take on that guideline because of the results of the study, I would say is the greatest accomplishment. That study will result in improved outcomes and improved survivals. So both in the civilian world and the military world. So contributing to that type of thing, I think, I'm very proud of that. And it's a perfect example of how my military career and civilian career are interlocked in this to be successful.
Yeah, wow, that's very interesting. And now, is that the program that you are the chief and founder of, or?
So that was a research study. It was done through the Resuscitation Outcomes Consortium, which is largely funded by the DoD as well as the NIH and similar organizations in Canada.
Okay.
So I was an investigator in that program. I was the founder of the Division of Trauma, Critical Care, and Acute Care Surgery, and the leader of that at OHSU. We founded that actually in about 2010, and I was responsible for recruiting all of the people in the division, which includes multiple people with military histories.
Okay.
So we have probably about 4 or 5 doctors that have been deployed. The other program that I'm very excited about that I brought here to OHSU is the Army Military Civilian Trauma Training Program, which known as AMCT3, which the Army in particular deploys active duty medical personnel to a civilian center, a high volume civilian center. So during wartime, there's lots of opportunity for people to practice their military medical practices, but during periods of low operational tempo, the place to do that is in the civilian centers. So the Army stated that, or determined that they were going to set up some of these programs, and we were the first one. There were 2 that were started, one on the East Coast, one on the West Coast. The first one, the East Coast was in Cooper, and the West Coast was here at OHSU. So we were the first program in the West Coast, and so they deployed 5 people here: 1 general surgeon, 1 emergency medicine physician, an ED nurse, an ICU nurse, and a CRNA, full-time active duty military to come work in our hospital. And they're doing high volume trauma care, which they wouldn't do in their military active duty status and military facilities. So I'm also quite proud of that program, which has really done well. They're going to send us a cardiac surgeon. They also send us an OR nurse, and they're talking about sending us some neurosurgeons. So great program, a great way for the military and the civilian world to collaborate.
Yeah, so I think we might have just done an interview a few weeks ago with a Major Stidman.
I don't know the Major Stidman.
Hold on. Well, maybe I can get his name towards the end here, but I think he is participating in that program. Very, very new to it. Sir, thank you for sharing that. I'm going to move on to question 2, which is, what is it like being in a deployed environment as a surgeon? You did kind of answer, a lot of this, but I don't know if you wanted to add anything to this particular question here.
You know what it's like? I'll tell you what it's like. It's like going to surgery camp.
Yeah.
So you live in a tent, and you and your team, basically you got a male tent and a female tent.
So when you say you and your team, like, what does that consist of? Like you being the head guy in charge of that team. What is your team like? What's the layout of the team?
So that's highly dependent on the environment and what's going on. So in 2014, I was in a forward surgical team, and a forward surgical team, the components of it is changing a little bit. But at that time, it was 3 general surgeons and 1 orthopedic surgeon. You had some emergency medical technicians, EMTs, and then you had ICU nurses, OR nurses, and ED nurses. And some enlisted personnel, administrative type personnel. It's about a 20-person team. And the team deploys and essentially the entire team responds to casualties as they come in. The majority of the casualties were actually local Afghans, Afghan National Police, Special Forces, some civilians.
Okay.
We took care of NATO and U.S. military as well, but we didn't see as many casualties from those groups. It was more of the Afghans, actually the Afghan local and nationals. And basically, these patients come in, you respond to them as a team. This is a tent environment. They come into what they call the ATLS tent, which is like an emergency department tent, small tent. Might house 4 or 5 stretchers. Give them initial care. Then you can move on to the operating room if they need to be in the operating room, and there's an ICU tent. And these patients are kept for several hours, and subsequently they're in Afghanistan. They were airlifted by helicopter to the next destination, which may have been a combat support hospital, in that case Bagram, or a local national hospital, depending on the situation. But it's really just like being in surgery camp. So you sleep when you can, you eat when you can, and you operate and you take care of patients and work out. That's basically all you do.
Right. Yeah.
And read books. I worked out twice a day. I lost 20 pounds.
Nice.
But at any minute you're ready. You could be taking care of casualties, and it could be a mass casualty.
Yeah.
So it's it's awesome. The only thing is, if you have a family, you miss your family, and that's the sort of the downside, is that anybody who's got a family, wife, children, etc., husband, you miss your family, but otherwise you're at surgery camp and you're working out, eating, and taking care of patients.
Right. Yeah. I know I can relate. So one time I did deploy in years ago when I was in the reserves. The deployment was very lengthy at that time. It was about 15 months. But I can assure you that, the time that I spent, because I was an equipment operator, so we would do any type of base camp construction to any type of drainage and road construction. So for 10 to 12 hours a day, I was on that piece of equipment getting very, very proficient, with what I was doing in the Army, in that deployed environment. So I would assume it's the same for you. So then I came here as a civilian because I was in the Army Reserve. And, I went in and I worked for Department of Public Works. I just walked right in and I said to them, hey, this is what I've done over the past year. They looked at it, was like, so you've been, I was an 18-year-old kid, 19 years old, walking in with all this experience from that deployment. And, from there, I had different groups fighting over whether they were going to hire me or not, like what department I would go to. So
I think that's an important point. I think in general, having had military experience looks really good on your resume.
Yeah.
Whatever training it is, your case, operations, mechanical operations, etc. My case, surgical experience. I think that is really favored for the most part when people look at your CV. They know you're well trained. They know you have good experience, leadership. There's opportunities for leadership, and it looks good on your resume. And many people, for me, I've been in the same place for 18 years. Every once in a while I look at a job and people, wow, you're in the military, you must be well trained, disciplined, and I think it's favored on your, it's looked upon quite well.
Okay, I agree. My next question is: are you working on any research programs currently right now, and if so, do you mind elaborating on them?
Oh yeah, we have right now. We have somewhere around $5 million in funding, primarily from the Department of Defense, but also from industry. We are one of the major projects we're looking in both animal and human models is the effect of stem cells, intravenous stem cells on ARDS, acute respiratory distress syndrome. ARDS was a term that was coined during the Vietnam War when we were resuscitating with a lot of fluids, and people were getting lung failure. And it happens after trauma, and we're studying whether we can prevent or treat acute respiratory distress syndrome with intravenous stem cells. And we have two studies going on right now, one in animals and one in humans, looking at that. We have a similar trial looking at prothrombic complex concentrate, which is a subset of plasma. And we're doing a field trial in Seattle, Portland, and Houston, looking at that drug to prevent organ failure and stop bleeding in the field. So all this combat relevant research. We have a number of clinical trials looking at various agents, drugs. We're very interested in hemorrhage control, early hemorrhage control. And we were one of the first sites in the United States to start using whole blood. So whole blood was something I learned about using with the walking blood banks in the Army. We don't have walking blood banks here. We have a stored product, which isn't as good as the one we use in the military. In the military, we take blood out of one person, and within an hour, we're putting it into another.
Oh, wow. Yeah, I was going to ask you what that meant. Okay, good.
Yeah, so fresh whole blood. Essentially, I mentioned that we had these in April of 2014. We had these mass casualties. I gave one injured Afghan 21 units of fresh whole blood. That meant 21 soldiers reported to the medical treatment facility and donate a unit of blood to keep this guy alive. And the blood, when it comes to you, it's still warm and it's got 100% of everything in it. If we could do that in civilian practice, it would be amazing. We're using whole blood. It's been stored, it's cold, and it's diluted with storage solution, so it's not quite the same product. So
I see, yeah.
If there's one thing we can do right now is to start walking blood banks in the United States, and that takes some work.
Well, what do you think? What do you think the holdup is? Is it just not enough people ready to go at an hour's time, or what?
The problem is that to be FDA, so in the United States we use formally FDA approved products extensively, solely. And it takes about 24 hours to 48 hours to properly test the unit of blood to make sure there's no pathogens in it, no viruses that could be contagious.
Okay.
what the military does is it screens all the potential donors for viral diseases. They know what your blood type is, and they know you're a potential donor. And then they do rapid testing on the blood that you donate. That's very quick, but only it's not 100% sensitive, and it can miss some pathogens. The blood that we use in the military has been shown to improve survival by up to 10 times. So the military believes, and I agree with them, that the small risk that's associated for infection in those blood transfusions is well worth the benefit, which is improved survival.
Wow.
That kind of thinking just doesn't fly in the United States. They want to, be 100% certain there's no viruses in the blood. So
Right.
that's probably the biggest holdup. We could do it otherwise.
Yeah. Okay. Man, that's good knowledge right there.
Yeah.
I wanted to ask you our fourth question here. So, just in your opinion, what are some of the preconceptions of serving in the United States Army as a medical professional? So, maybe some of the things that you've heard about your Army career, or some of the things that you see in the field. If you don't mind sharing, kind of what you think, some of the preconceptions are.
Would that be for like a medical student or someone who's thinking about an Army career?
Yeah, somebody that's thinking about. I just want to base it on like a medical profession here in the Army. Like, and I would say maybe. I don't feel like serving, 3-4 years in the Army. I'm only interested in the education benefits, but I don't want to give my time to serve on active duty. Something like that.
Well, I think people are concerned about in general, signing a contract with the Army because, once you sign that contract, they kind of own you a little bit, right? And people, I think, are worried about where they may end up and will they have a good experience. What's the operational? If it's not a time of war, could they be deployed and not actually take care of any patients? Will they do their specialty, in a deployed setting? I think those are some of the concerns that people have. They're worried about a commitment, and could the commitment be extended under various circumstances? Could they be sent to do something that they don't want to do? I think these are some of the concerns that people have. I do think that I've had a spectacular experience with all my deployments and everything I've done. I'm the kind of person that makes the best of any situation.
Right.
But I've always been deployed when it's busy. Iraq was busy in 2005. Afghanistan was, the busiest ever was in 2010, and Afghanistan very busy in 2014. I think the people that are being deployed now are not having that same experience necessarily because the operational tempo is way down. I talked about forward surgical teams. Now, because we don't have a centralized war with highly concentrated numbers of casualties and they're more spread out across the world. In the medical field, they're going to more austere surgical teams, and these are teams of 4 or 5 people that might only be able to, they go out with a truck or a helicopter. They have a pop-up tent to operate in and carry equipment on their back, and might be able to do 1 or 2 operations. And it's much more austere and it's a different environment than the one we saw in Iraq and Afghanistan. So people probably worry about that, don't know what the situation will be when they're actually going to be deployed. So I think these are sort of the concerns that people talk to me about when they're thinking about a career.
Right. Okay. My next question is, I just kind of threw it in the middle here. I just want to ask you, do you have any hobbies, if you don't mind sharing what they are?
Oh yeah, absolutely.
Hobbies, yeah.
Love to hike.
Okay.
My wife and I, we've climbed Mount Rainier. We've hiked all throughout the Northwest. Love the coast. Run, stay in shape. I think one of the things the military gets you in a habit of doing is staying in shape. If nothing else, so that you can still fit in your uniform.
Right.
As you get older, that gets harder sometimes, but I've done okay. But I'm active, like outdoors, like to travel a lot throughout the country, around the world. In my position, I do a lot of speaking, and a lot of what I speak about is my experiences in the military and how they shaped my civilian medical career. So that's what my wife and I like to do.
Nice. Awesome. All right. This question is question number 6. I want to talk. We did kind of touch up on schooling. We did talk about the HPSP. When you first joined. But did the U.S. Army cover all your schooling to become a surgeon? Like, the whole pathway?
So basically, they pay for medical school, and they provide a stipend, and they pay for all your medical equipment. When you go on active duty, so I was actually in the regular Army when I was at Madigan. So you're paid by the military. Life, everything is covered in terms of living expenses, your salary. Basically, when I was in residency and fellowship, I was paid by University of Washington, and I wasn't doing anything with the military at that time, so there was no financial transaction. And then I was on active duty for 4 years in William Beaumont, and again, expenses, medical expenses, living expenses, salary, all paid for. And then as a reservist, actually you receive a bonus every year. I signed up for a 4-year bonus. It was $50,000 a year. In the middle of it, they increased it to $75,000. Unfortunately, I couldn't increase it. I had already signed the contract, so I was stuck at 50 till I finished my 4 years.
Okay.
I'm actually beyond my mandatory retirement date. Because I like it so much, I stayed on, and you have to get a general to sign off on that. A general in your command structure signs off on an extension before your mandatory retirement date. And I don't plan to ever get out until they make me.
Yeah. Good. Nice. All right.
I got to tell you though, one thing I would say is it's not about the money. In the end, the money's a wash. I think because those 4 years of active duty, you may not make as much money as you would in the civilian world. So I wouldn't do it for the money. I would do it for the career enhancement, and I think that's where it's at. When you're in the situation, you're in debt and those kinds of things, it feels like you need to do it for the money. But that for me was a long time ago, and admittedly a lot smaller debt than people are having now. But for me, it's for the career enhancement, not the money.
Nice. Okay. Well said.
Yeah.
Next, second to last question here. If you could change one thing about your military career, what would it be?
I wouldn't change anything. I continue to be interested in, I'll tell you a quick story. I'm what's called an IMA, individual mobilization augmentee.
Okay. Yep.
So that designation, which is shrinking in the Army, they're having less and less of those. What you're supposed to do in that designation is you do your 2 weeks of training in a facility, and the idea is if someone gets deployed from that facility, you backfill them.
Okay.
So I've never done that, and turns out that I never actually had to be deployed, but as an IMA, it's all voluntary.
Okay.
So I volunteered, to do this, not knowing that it was voluntary, but I did it anyway. And I'm still interested in further deployments, and something where I can use my leadership skills. But I can't look back and tell you I regret anything I've ever done. I really, I've had a great experience. I did officers basic in Fort Ord in Northern California. Loved it. I did airborne school. Loved it. I've had a great experience. I don't regret anything.
Okay. All right. Very good answer. And now, sir, last but not least, I want to ask you if you could give some advice to students that may want to pursue a career as like a medical doctor, say like an HPSP, somebody that is thinking about doing it. What advice would you give them?
I think it comes back to what I said earlier. Obviously money is an issue, but don't do it solely for the money. Do it because you're interested in the military as a career. Look at it as an opportunity to enhance your career and further what you're doing. Don't always do exactly what the military tells you to do. Hopefully none of my commanding officers are listening to this, but I've been asked to do a lot of things that I didn't think were in my best interests, and I pushed back a little bit. I never refused an order, but I did a critical care fellowship, surgical critical care fellowship, and the first two assignments that they were going to put me in didn't have ICUs. So I pushed back a little bit and said, well, I'm ICU trained. I've got skills to work in ICU. You should send me to a place with an ICU. And with that pushback, I ended up in the right place, which was William Beaumont Army Medical Center.
Yeah.
ICU, did trauma there. So, don't refuse orders, but, you might push back a little bit if you don't think that your assignment is in your best interest. So that may or may not work for you. I think once you're in the military, make friends. Get to know people, because what happens is you come back in contact with them multiple times in your career, and you never know who's going to help you out when you need help.
Right.
And so treat people well, do a good job, and make friends, and take advantage of those friendships when you need them.
Yeah, and sir, to add on kind of what you're saying is so I kind of went on Global and started emailing just a few surgeons here in the local area, and it just so happens that I ended up just randomly emailing you, and you got back to me, and the story you shared with me was you actually spoke at one of our annual training conferences that we've had as a battalion just some years ago.
14 years ago.
Yeah, I mean, and it's just crazy that everything goes around, and just to add to exactly what you were saying, like, it's a small world. It's just small little Army community that you never know who you're going to run into. And but with that said, I want to open it up to see if we had any questions that were lingering.
Okay, first question I see is, while you were in El Paso, did you ever go to Chico's Tacos? I didn't go there. My favorite restaurant was Doña Lupe's, which has great Mexican food. I never went to Chico's. I drive by it. I never went there, but I've heard it's good.
I've never been.
Were you in El Paso?
No, I've never been. No.
Right.
Yeah.
There's a place in El Paso called Carlos and Mickey's. Best Mexican food and the best margaritas ever, if I'm allowed to say that.
Okay, I'm writing this down. Say it again.
Carlos and Mickey's.
Carlos and Mickey. All right.
The only downside is my friend, I mentioned my best friend we got married with, his car got stolen from there and ended up in Mexico. There's a question from Sergeant Villa. How does that program, the AMCT3 program, benefit OHSU and the Army? So the Army gets to have their military personnel work in high-volume trauma centers and maintain their skills, which is really important in low operational tempo times. The civilian center gets free labor. So, we have a surgeon, partner. We're not allowed to pay him anything, and he works hard. And so we benefit. We augment our forces, and don't pay anybody. And the military benefits because of the ongoing skill maintenance.
That's interesting. All right.
Yeah, that's the idea. And, the civilians may actually benefit further. I mentioned the legislation, the Mission Zero Act, that can pay up to $1 million for a civilian center to house these programs.
Okay.
So these, I think, for the military people, being able to work in the civilian centers, it'll extend their careers. They'll stay in the military and do this, and because it's a great opportunity.
Yeah, and all this time is going to add up for their retirement, right?
Absolutely, they're on active duty. Just like they've got orders. They're deployed to OHSU. It's just like any other full-time job where they're working in the military. So these programs are proliferating around the country, and more places are participating.
Nice. All right. I got a question here. Which has been your most rewarding publication?
It's the one that's coming out in August in JAMA, Journal of American Medical Association. In August, our tranexamic acid paper is going to be will be published. So that will be the most. I'm the senior author on that paper. It represents, what I think is probably the most important work I've done. A couple other papers. We wrote a paper. We did a study, another pre-hospital trial with the Resuscitation Outcome Consortium, looking at hypotensive resuscitation. We basically used the resuscitation protocol from downrange and applied it to the civilian setting, and we proved that if you use a hypotensive resuscitation protocol, you can actually improve survival. So I think that's I'd say the second one that I'm most happy with.
All right.
That also changed practice. The third one I would mention was a study where we looked at 1-to-1-to-1 plasma to platelets to red cells, which is sort of recreating whole blood, versus 1-to-1-to-2, and showed improved early survival with the resuscitation that resembles whole blood. So those are all three of those studies have changed practice, and real proud of those.
Nice. I'm definitely going to be looking out for the publication that comes out in August. I want to take a look at it.
Yeah, it's going to be really good.
Let's see if we got any other questions that are out there. I'll give it one last sec here. But I wanted to thank you for your time. It's been a pleasure talking with you. I learned a lot. We did go about 20 minutes over the time that we talked about, but again, thank you so much for your time. I look forward to maybe doing this again somewhere down the line.
Absolutely.
Once things start to kind of open up a little bit, I would love to make a trip to OHSU and maybe meet you for lunch and kind of meet some of your colleagues and kind of go from there.
Absolutely. I've got a coin for you from our AMCT3 program.
All right. Yeah, I'll definitely have to come by and check it out.
All right. Sounds good.
Sir, thank you so much. I appreciate it.
All right. Take care.
Thanks, sir. All right. So thank you so much for your time. I wanted to share, if you got any questions, you could reach out to our Facebook page at Vancouver Medical Recruiting, our Instagram page at Vancouver_medical_recruiting, or our YouTube channel. Please subscribe, Vancouver Medical Recruiting Station. I am Staff Sergeant First Class Ryan McDonald with the Vancouver Army Medical Station here in Vancouver, Washington. If you'd like to reach me, my phone number is 702-743-4479. Thank you for listening, and I hope you have a great rest of your day.